incredibly impressive and really good to hear the whole journey that you've been on. So, yeah, I mean, I think that you've supported the significant change, I think, in how we handled COVID, and really fantastic to understand and hear that you've been able to pivot to other diseases as well. So just really fantastic work. Thank you. Okay. So we open it out to the floor. I've got lots of questions, but I'm going to give you a minute to think whilst I perhaps ask a couple of questions at the beginning. So you mentioned, Dr. Abbas, 5 to 10 years to recoup some of that money. So I just wanted to, given that everything that's going on now, how do we prioritise that?
So as in where should those funds go?
Well, I guess it's about, if we've got all these different options, is 5 to 10 years, is that something that we can wait for in terms of the return on investment?
So I think we're going to have to be patient, because the problem is so big. So the funding hole in healthcare is so big. And because it's so big and because it's so stark, the danger is that we'll spend the money we have now on solutions that are short-term. Because it'll make us feel better and we'll see an impact maybe in a year. But the problem is, in 2 years' time, the problem will be worse. The funding hole will be bigger, and the same burden of cardiovascular disease, or not greater, will exist. So I think it's really important now we actually go, rather than spending on short-term solutions, because that's what we've done for the last 10 years, actually we need to focus that on 5 to 10 year solutions. And the reality is cardiac CT is something that needs funding. So that's where I would focus it on.
No, thank you. I think that's very pertinent. And I think it was actually at the last GovConnect conference that I came to, that the person who's chairing the session from NHS Confed talked about the split screen thinking. So it's absolutely, we've got to deal with the urgent stuff now, but we absolutely have to have the other screen open too, where we're looking at that kind of medium and longer term solution, so that we can start to turn some of those taps down, turn the water down, the flow of people coming through. Yeah, so great. Okay, so questions for our fantastic speakers here? Do we have microphones or? Sorry. You first, and then second.
Thank you very much.
And perhaps if I take those two questions together.
Okay. Thank you very much. My name is Sandra from the at-home service with Guy's and St. Thomas's. My question is for Dr. Rahul. Thank you so much for the presentation. It was really mind-blowing and eye-opening. But I've got a question. Is there any plans underway in terms of management level to get these services integrated into other emergency services, especially within the trust? Like for us with the at-home team, we run a sort of urgent care service, and having such point-of-care diagnostic tools would really be helpful for shortening patient stay and improving the service in general.
Yeah, so I think Epic will be the driver for that. And part of the reasons why we didn't move into some of the other areas in the hospital, especially in urgent care, is because in urgent care, the patients don't have a hospital ID, essentially. They have just their NHS ID at this point in time. So when we move into Epic, everybody who comes through the hospital will be given an Epic ID, and that can drive the ability for us to then put these rapid diagnostics into all areas of the hospital. So there is a plan, once Epic comes in, to spread this type of testing wherever we can, and that's from a higher level, top down.
Within the at-home team, we also use the e-noting system. So our patient has got hospital numbers as well. So
oh, okay. So
exactly.
yeah. So our next step from here is to offer this to the at-home teams.
We need it.
Yeah.
Yeah.
That was the right answer.
Just to point out, we do have point-of-care blood tests, but that's just basic. We don't do any D-dimes or anything else. Please bring it over to us.
Yes. That is the plan.
Shorten our length of stay.
Yes.
Good.
And if you have those ideas, then tell us what you need, and then we can develop those solutions very quickly for you.
I love this. We've got innovation happening in the room. You know, it's so good. So that's brilliant. So you can action that right now, I think, and just create that improvement. So thank you. Yes. Next
Hi.
question.
So I had a question earlier, but we were asked to hold our questions for this afternoon. So it's a bit more general about
Sure.
software applications and digital transformation. So we're hearing a lot about digital transformation and software applications. And a gentleman that was speaking earlier actually said that there's actually more autonomy being given at a local level to implement digital solutions. But from experience of working at a trust, we at my last trust, we had over 200 software applications just in one organisation. And during COVID, in that organisation, there was a lot of executives that went out and procured a lot of different applications. Some worked really well, some not so well. So it seems like there's definitely a plan to look at the data flow between these systems through API integrations. But if you join up all of these systems, you've got the data flow. But in terms of all of those different contracts, that's huge financial waste. So is there, in the long-term plan, a sustainable way of addressing this?
Well, that's a very big question. So I've got thoughts on that, but I'm going to actually just open it up to our panel. I wonder whether, Douglas, you might make a start on that, because we've seen such a wealth of, not to put you on the spot, but we've seen such a huge plethora now of different mental health apps, and to your point, I mean, I want to flag regulation actually, and we've got other people in the room. I think, I don't know if Leah's still here somewhere, but that's a big issue generally, and getting through things like DTAC, etc. But anyway, let me ask you to start off. Yeah.
It's a tricky one, because you want to have as wide variety as possible so you can capture lots of things, but at the same time you have to make sure that the systems are safe. So because we've been around a while now, we've done the DTAC, we've done the previous incarnation of that, they've got the NICE regulation, so we're contacted constantly by people who've created an app.
Douglas, sorry, would you just say what DTAC is? I just realised.
I can't remember.
It's just to explain the process, I guess.
It just makes sure that you're
It's a clinical safety case.
Yeah, it's a safety case. It just makes sure that you've got all the right processes in place, that you know what information governance is, and you've got a clinical team to look at things. So there's lots of people. I think COVID has distracted us a lot. I think now that we're coming out of that, some of the structures have come back into place, and I think some of the commissioning arrangements that were previous there with the CCG have now moved over to the ICSs. I can never remember all of it. And there's just some knowledge that needs to be started about what is a good system and what are the criteria you have to have in place for those to be done. But there is a problem. There is another part of it as well, is that the financial world has changed for a lot of these startups. It's got a lot tougher out there. A lot of them are going to disappear, and there will be an amalgamation of them. So as with anything, things will change. But I do think there's something around the commissioners and the people inside the trust, making sure they've got systems that are safe to use.
I think the other thing is that without sort of complete national standardisation, if you look at Wales, for example, they're very aligned. Like when they roll something out, they get all of their 7 health boards to meet and to agree on, like they'll do an optional appraisal of 2-3 systems, and then they'll agree on one to roll out nationally and configure it locally, depending on the population needs. I mean, do you think a model like that is achievable? Because I feel like we've gone so far down one way that we've sort of, by solving one problem, we've actually created another one.
Yeah, your issue is that if you start having only one program that everyone uses, it can be very difficult for other programs to come along that are better than it and entering into the marketplace. We've moved, like, IAPT has been a really lovely place to start, because you've had modern data systems talking to each other, trying to make it good for each other. Then you move into another system where APIs aren't so accessible, there's still systems out there that won't let you connect to them. So having a national system is fine, but you still have to have a bit of competition to make sure things are done properly. But it's a real challenge. But I think the financial market might solve some of this, because I think a lot of them will disappear.
And I guess one of the other issues is about, obviously the long-term plan, but throughout the NHS, it's about reducing inequalities. We know that we need particular solutions for particular populations. So again, I think it's just, obviously the plethora is too much. It's gone, as you say, too far one way. But equally, we do need to allow enough difference in there and enough personalisation. We all use different apps, don't we, for whatever it is, whether it's our fitness or our, Calm or Headspace, whatever we use different apps. So, because they suit us better. So there just needs to be a balance between both of those things, I think. But I absolutely agree that it becomes really impossible when you just have so many, even evaluating which one is it has enough of an evidence base, etc. It is quite complex to do. And we're asking commissioners who may not necessarily have that skill set to that depth to make these kinds of decisions. So I absolutely agree that we do need to, at a national level, have more formulation around this than perhaps we've got right now. I think it's happening, but we need to go further. It's a really good question. Thank you. Okay. Yes, here, down at the front, got Fabida.
Thank you. Hi, I'm a psychiatrist and medical director at Birmingham and Solihull. My name is Fabida. It's really interesting afternoon, just like the morning. Thank you. I was just trying to coordinate everything that you all said, and I was wondering, there's a lot of scope for, and we discussed it in one of our workshops, about physical and mental health digital solutions together. And Shri, from your talk about severe mentally ill patients, rehabilitation, is that a cohort of patients who would benefit from your tests and your cardiac CT and your digital solution? And do we need to think more creatively about joining it up? And in the workshop we had before, someone was saying about how can some of the solutions come to the psychiatry hospitals to have a quicker way to access 4 or 5 specialties, because they may have multiple chronic conditions. So I just wanted both views.
That's a great question. I'm going to actually ask all of you to answer that if you could, because you can flip it around, because physical health and mental health as well. So would you like to start?
Yeah, sure. I think one of the things that we've found is that I agree with you that we need these type of solutions, and the issue that we see is data movement, right? It's the information governance that blocks the ability to share data in the way that would be most helpful for patients, right? And during COVID, we did see some of the red tape removed around information governance. And what we hope, along with the long-term plan, is when we reach this core level of digitization within trusts, that we can share information more easily between trusts, and that will hopefully address some of the concerns that you have. So if you have a purely psychiatric hospital that can share patient-level data with another specialist group, then they can look at those chronic health problems and offer interventional strategies to those patients in one enveloped visit, rather than this disjointed GP visit to another specialist, and while you have somebody that's already an inpatient in a psychiatric area.
We've been wanting this for a long time, and I feel like ICSs have to make it happen now.
Yeah.
Yeah.
Yeah, I mean, the bane of the on-call radiologist is the person who's had chronic imaging in London, and they come to us to have an acute aorta scan, for instance, and we don't know what their old scan looked like, even though our colleague in London would. In Scotland, they've got a national PACS, so they've got a national system where if you get seen in Edinburgh, you can see the X-rays that were done in Glasgow, and I think we should be moving towards that. The only problem with scaling up something like that is it then means that individual trusts or regions can't personalise solutions that they really like. and everyone has to do the same thing. And then the other flaw is if one PACS system goes down in the UK, the whole of the PACS goes down in the UK. And we see that in our region where one error in an update can take away the entire radiology imaging viewers for the whole of Hampshire. If you replicate that and you make that the UK, that becomes a really even bigger problem than it is. But I do think we do need to move away from this thing where data about patients is known in one hospital, but they happen to be on holiday and no one can access it, because lives are saved and diagnoses are missed because they don't know what was happened in the past. And I think imaging is particularly pertinent too.
Thank you. Douglas.
So in the IAP world, we've been trying to deal with long-term conditions for a long time. When I ran an IAP service, I was asked to look at the number of diabetics that were present in the IAP service, and there were hardly any, and it was a real surprise. And I think the thing that comes across sometimes when you look at the feedback from the patients is I'm surprised this worked. And I think we just need to get more of the CBT model and the other therapeutic processes into the physical health areas so they're co-located. So we're no different from our patients, and I'm constantly surprised it works. So just getting the access to doing a little bit of CBT and a little bit of knowledge gaining and a bit of psychoeducation can really change people, the way that they see things. And it is just about giving people more access, and co-location is the key for me.
And that's such brilliant answers, and such a variety of thinking. Again, I guess that the ICS is really that co-location. It opens up that door a bit wider than it currently is. So, yeah, let's see where it takes us. Okay, so we've reached the wrapping up section now. So well done, all of you. Stayed, till the end. But I think it's been a real privilege to hear, this wide-ranging set of talks really spanning across such a lot of the care that we need. And you can see how they're going to all significantly contribute to the delivery of the long-term plan. So I think, Douglas, thinking about mental health, obviously there's been so many comments around mental health being the second pandemic, and it's not going away. So to hear about what you've been doing and how you've progressed Silver Cloud has been really, really, really kind of excellent today, and it's such an invaluable service. So thank you for all that you're doing. I was really interested to think about this whole kind of fully digitalising end to end the whole process and the therapy. And I guess one of my kind of one caveats would be, how do we make sure that people who can't, how the excluded group, and that's my group, rehab. So to make sure that we're not forgetting about those. And I wonder whether that's some of the innovation that needs to happen now of those. And again, the inequities we know about, people of colour and how IAPT doesn't perhaps serve them as well. So that would be amazing if some of the innovation is around those groups and improving those inequalities and making them kind of culturally sensitive and more accessible, and that reasonable adjustment for my kind of population in rehab. But really invaluable, and I'm going to remember that now. So the no health without digital health, great saying, and bringing parity. So then I think just moving on, to the cardiac work, and certainly I think Dr. Abbas, you've convinced me, certainly, and I don't know, hands up in our audience, how many people are convinced? Oh, you've done a good job.
That's good.
Okay, so, clearly, one of the things that really stood out for me was, and I was going to ask you this question, but you answered it, and it was really, well, we know that lifestyle changes help, so why don't we just do the lifestyle changes? Why do we need to scan people? It's expensive, all the stuff that you've talked about, workforce and so on. And then you said, just by seeing the scan, the patients change their behaviour. And that is a really incredible piece of knowledge. That's the difference. We often know, don't we, what we need to be doing, but it's how do we affect the behavioural change that drastically changes outcomes. So really brilliant to hear that, and so thank you for bringing that to our attention. I think we'll be advocates for you. So the other question I had, I guess, and maybe we have to hold this in mind and think about it, is the whole of AI coming to reporting and obviously pros and cons, but given our workforce, if we can make it a pro, that would be really valuable. And then we came on to hear about some really incredible innovation from Dr. Batra and the team that he's been working with, and it feels like you did change the course of what happened in COVID for us. Partly, I think, it sounds like you had a hand in that, so thank you. And I guess just there, thinking about the future of diagnostics and this whole ability now to shift it to different diseases very quickly is really quite incredible, very innovative. And the whole sort of making it portable, taking, you could see it in motion, all the different issues, and then iterating and improving, seeing it in action is quite something up there, and living through it must have been quite something as well. Yeah. And of course, I'm going to talk about mental health rehab. I'm not going to miss the opportunity. And for me, I feel as though the opportunity is to ensure that we have some key metrics and that every integrated care system ensures that they take responsibility for that cohort of people. It's quite a small number, but you can see there are big amounts of cash involved and really not good outcomes right now. The variability is huge. Really good practice, lots of variability that we need to improve, up-leveling it all. So I would say, very strongly that there are a couple of key metrics at every IC integrated care board that need to be in their dashboards that they're looking at, about keeping people in area, keeping people in the community wherever possible, and having that whole system approach for rehab. So then it just gives me pleasure at the end of this, it leaves me just to say a huge thanks to all our speakers for sharing your knowledge today and giving your time, but actually for all the incredible work that you're doing. So please keep that up, and it'd be fantastic to hear maybe in a year or whatever what you're doing and how it's all progressing. And maybe another one of these. And thank you, Tony, and GovConnect, all of your team, really putting all of this on. We're all here today because of their efforts and work. To our sponsors, many of you are here on bursaries because of our sponsors, so big thanks to them as well. And obviously to the RSM, our IT people at the back there, our catering, made it all really run smoothly. And last of all, a great thanks to all of you for being here, for making this a really fantastic and interactive day, and I hope you've all learned something, take something away that you can implement and think further about. Thank you for all the work that many of you are doing in our healthcare systems as well. So thank you. Safe journey home.